What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
Kane, we've been waiting for this one. We've been itching to talk about that. We've hinted at it in nearly every single episode, and today we finally get to get it off our chest. Today is the MDT, the McKenzie overview episode. So like I said, in previous episodes, Kane and I have referenced this method. We have thrown some terms out there. Today we want to formally introduce it, just discuss it, talk a little bit how we work it into our practice, and just for people who are new to it, give them an understanding of how they can begin to immediately implement it into how they treat people with pain.
All right. So, Mark, can you tell us a little bit more about what exactly MDT or McKenzie is? It seems like there's a little bit of a confusion from how MDT practitioners recognize, acknowledge the system versus how other people may perceive it. So let's kind of clear the air up right from the start.
Yeah, so first and foremost, MDT, Mechanical Diagnosis and Therapy, McKenzie, it is a evaluation and assessment technique that is used to treat people with pain. Depending on what's assessed, and it's based off classification. You assess an individual, they match a certain classification based on subjective and objective findings, and then based on the classification, it allows you to treat them when appropriate, right? So I think historically, it's been introduced in the spine. It applies to any joint in the body, those including extremities. And I think when people get an introduction to this, they think of prone press up, right? Repeated extension line. They think of lumbar spine pain with leg pain. They think of disc, radiculopathies, things like that. And sure, it started there. It's certainly effective in treating those presentations. But I think the thing that people miss and misinterpret is that it's first of all, it's an assessment and evaluation technique based on classification, and it can be used to treat anybody with, we'll say, mechanical pain.
So one of the things that I actually noticed and that I also want to stress is exactly what Mark said, is that McKenzie or MDT is utilized primarily as an evaluation technique and as a classification system. Whether you decide to use the exercises that MDT is popular for is a completely different story. I think that utilizing it as a framework is doing it justice already. And then when they fit into one of the classification systems, which we're going to go into later on this episode, I think that just makes our job so much easier. It becomes a whole lot more standardized as well. And ultimately, I really do just see better outcomes, faster outcomes for our patients as well, too. And I think that when we're able to classify a lot of these patients and figure out what exactly they're going to best respond to, usually that's when we come up with a better prognosis for our patients for the most part, because we're just able to find the correct exercise for them. And I think that that's probably one of the biggest things that MDT helps us do, is it helps us be able to match the intervention with the impairment. That's probably one of the bigger things that I've noticed, is if someone isn't very familiar with McKenzie, they think of just MDT exercises or directional preference exercises, and they just throw them all up onto the wall and see what happens. So, Mark, why don't you tell us a little bit more about like how that could be a little bit more problematic versus like the approach of how it's supposed to be utilized?
Yeah. So, like Kane said, I think you have papers from the 90s and 2000s, maybe even some as recent as like the 2010s, where someone has back pain and they do the McKenzie exercises, and they essentially do a full extension progression, full flexion progression, when they're missing the entire point of the system, which is how Kane was saying, is to classify an individualized treatment. You're not just doing a bunch of exercise and hoping something works. You're doing an exercise, gauging the effect that the exercise has afterwards, and then teaching the person to self-manage. So,
It, that,
yeah.
that's probably one of my biggest gripes with a lot of the CPGs that we have for spine is this is something that you and I use primarily as our first line of defense when it comes to treating spine, but it's considered to be C-level evidence for treating spine.
Yeah.
And I think we for sure understand why now is because if you're not appropriately utilizing the system, how are you grading it?
Well, you should. Yeah, we had a Sorry, oh my god, I'm so triggered right now. Let me say it. Whenever the most recent like low back pain CPG came out, was 2021, 2022, or even if it was more recently, whatever. I participated in the journal club for this, and like you said about that C rating or whatever it was, if you and those studies I referenced that talked about doing the McKenzie exercises were the ones that made it into the CPG and gauged that rating off of, and it's just like insane. Like they're not like the one. It was like they're doing like 8 different exercises and they're all counteracting each other. One of the other ones was the patients were evaluated by, it was, I think, quote unquote, someone familiar with the McKenzie method, or like someone who had just taken part A. It's like, what kind of standard are you setting to be able to say that you can effectively implement this method if you're familiar with it, right? I just want to based on that, a little disclaimer. I'm credentialed in MDT. I'm certified. I'm not saying I'm some kind of expert or anything like this. I think just passing the test means I've demonstrated the minimum amount of knowledge necessary to, use the method or explain it. So I'm not, Ken and I, we're not saying we're experts by any means, but just want to throw that in there. But yeah, like the data we have on it, it's based off, the data's bad, right? It's not, and I'm not saying this is the end all be all for PT, things like that, but I think to fairly assess an intervention or a method, you need to have people who are actually utilizing it appropriately collecting the data.
Yeah, I think that definitely. Let me put it this way: proficiency matters when you're trying to evaluate how effective an exercise or intervention or a system is, right? Like, obviously, if you have someone who's familiar versus someone who is competent versus someone who is an expert, like, you're gonna get varying results. And I think that this is where understanding the system works phenomenally, because the reason why I think Mark and I enjoy the system so much is because of the standardization of the evaluation, the assessment, and then the interventions. Like, there is a pretty much an algorithm for the force progression to know where you need to go, how to interpret symptoms, etc., etc. It lays it out so that as you become more and more familiar with it, you won't have to refer to your cheat sheets as much. It just becomes a lot more intuitive. That way, it becomes more of a universal language for people who practice utilizing these techniques. It just becomes so much easier to discuss cases, know exactly where we are, and then how to move forward as well too. And that makes being able to treat a variety of patients so much easier, going from one clinician to another. At least we are starting to speak the same language and understand each other's thought processes as well too. And that's probably one of my favorite things about the system, to be honest with you.
Yeah. I mean, if we want to talk research wise, like we take a look at the intra and inter-rater reliability between classifying patients between MDT credentialed clinicians, like it's high, right? So when we talk about continuity of care and PT in general being able to speak the same language and properly assess and classify patients, I think this method checks all those boxes.
Yeah, I would definitely agree with that. And that kind of segues into our first topic of the day, right? So one of the things that MDT is very, very well known for is their traffic light system. So, Mark, why don't you tell us a little bit more about this system? And I think it's so wonderful. I don't use it specifically for MDT. I use it for almost everything that I utilize.
That's the right answer. So traffic light system, it is a built-in safety mechanism. I think it lets you properly understand symptomatic response that patients have in response to movement, and then it lets you determine what you do with the patient based on the response, right? So we have our green light, which means that the patient performed a movement and they had a lasting improvement in symptoms after the movement. Okay, we'll interpret all these after, but we'll just give a basic overview. Yellow light: the person performed a movement. Their symptoms afterwards were either their symptoms improved while they did the movement, or they got worse, but they didn't remain better or worse after the movement. And then we have our red lights where the symptoms were changing during the movement, and then they remained worse or were peripheralized after the movement. So you have this system. It's at green lights. You kind of already know what's going on. You have your answer. You have the person do something. Their symptoms were better, centralized, or abolished afterwards. You've determined the correct movement. You've determined the correct dosage. You really don't have to do much more from there. You have your answer. Yellow lights, like we said, they're performing the movement, and it's not better. It's not worse afterwards. It's more or less a neutral effect. Depending on the symptomatic response, if let's say it got better, but it didn't stay better afterwards, you're probably going to progress forces, which we'll talk about later. If their symptoms were worsening, but they didn't stay worse after, you still could progress force, but you might want to give it another set, maybe some more reps. You also have the option to look at like sustained positions if you were to repeat it instead when you get a yellow light. The red light, their symptoms are worse or peripheralized afterwards. You either need to look at a force alternative, which would mean changing positions, maybe going from repeated extension lying to repeated extension standing, or you're regressing forces. So if you were doing, let's say, patient overpressure, maybe you just go to a regular type of movement without any overpressure, which we'll talk about these going forward. But that's the basics of the traffic light system. Like I said, it's based on a symptomatic response. Depending on the response, it tells you which direction you need to go. Do you need to stick with the same movement? Do they need more of the same movement? Do they need more force? Do you need to pick a different movement or a whole different direction altogether?
Yeah, so I think what Mark stated was fantastic. It pretty much just gives us a clear cut system that we can follow. If things are green, that's good. We've already determined, like Mark said, the force, the dosage, and then we just need to give them the frequency that they need to perform their exercise for home. Red light is usually, okay, well, maybe we need to change forces. Maybe we need to regress it, or maybe we need to change directions. Either way, red is still giving us good information, right? It's not something that we need to necessarily be afraid of, but it's just something that's like, okay, it's just telling us maybe we're going down the wrong path and we got to change where we're going. Yellow is where things tend to be a little bit more up for interpretation, right? And I think that this is where, when I was first learning the system, I learned it as, the basic green, yellow, red. But then we actually delve a little bit more into this. What happens when you get someone who does it? And just like Mark said, things are feeling better, but then their symptoms come back. Or maybe things get worse and then their symptoms still come back to their normal baseline. That's not terrible, but it kind of gives us extra information, right? And just like Mark said, if things are trending yellow going towards green, we progress force. Things are trending yellow, going to red. Give it some more time. Let them utilize more reps, more frequency. See what it kind of needs, right? Like, it's better to be a little bit more conservative here rather than jumping the gun and making their symptoms kind of flare up. The other thing I want to touch on is Mark stated or utilized a couple of terms that I just want to make sure that we clarify right off the bat, right? Which is centralization and peripheralization. Mark, since you're the MDT expert,
Yeah, I'm the
at least between the two of us.
Yeah, I'm the authority on MDT in the the state where we reside, actually in the entire country of the United States now that I think about it. So let me speak on this. Yeah, so centralization, it's like the and I don't know if the way this originated is sorry, back in the 50s or 60s, Rob McKenzie had a patient, leg pain, back pain, put him on a table. The table was inclined like 45, 60 degrees, and by accident, the patient laid on his stomach and his symptoms went away. And then, Rob McKenzie started to develop this method. These, that was his first observation of the centralization phenomenon, which was we now define as distal pain moving more proximally in response to a movement, right? So someone has pain in their foot, they said bend backwards a couple times, it moves up to the back of their knee. Hopefully, ultimately, moves centrally into the center of their spine. That's centralization. But you can have centralization that doesn't go to the spine, right? So regardless, Kane talked about proving prognosis earlier. Centralization it's a big positive prognostic indicator. It's essentially the person's body saying, "Hey, we did this movement, we like it. It's moving the symptoms from more distally, more proximally. This is telling you have a green light. It's the right thing to do." On the other hand, we have peripheralization, which is opposite of that, right? Someone does a movement, sustains a certain position, and their symptoms move proximally to distally in the opposite pattern of centralization, which we know as a red light, and prognostically it's negative. So, those are two important definitions, right? Especially when we talk about the most important category, derangement, coming forward. Centralization is something that we're looking to occur. We're looking to monitor in response to movements, and so prognostically, it's very positive.
Now, there is one thing I do want to add to centralization, and not necessarily to the definition, but Mark did say that it is a positive indicator for their prognosis. Centralization is probably one of the biggest things that if I see, I'm like, awesome, we are on the right track, keep going. Right. But one of the things that can pop up is as their symptoms continue to retreat back up into their spine, as they continue to centralize, you may check, like maybe they have symptoms in their foot, and then you're like, okay, how's your foot doing? Oh, that's gone. But now my hip is really bothering me, or maybe my back is really bothering me. Like you have an increase in pain, right? That is totally normal. If you are still centralizing and you have an increase in pain that is more proximal, that is still a good sign. Please do not be super concerned or afraid or misinterpret that as a red light. That is still a good sign. Keep going. See how far it will continue to centralize and see if those symptoms continue to reduce, right? Yeah. So that's another phenomenon that can happen. It doesn't happen terribly often, but it still definitely does happen enough where I'm like, hey, definitely keep an eye out on this. Don't be super scared. It'll happen. When you see it, you'll see it, and then you'll know what to do then. Okay.
Yeah, it's amazing. It's an amazing point, Kane, because, and we've talked about this in previous episodes regarding reassessment. You might have someone come in and they say, "Oh, my pain's worse. Like my back is really bothering me." Or you say, "Okay, what's going on?" Like, let's say they had leg pain and they had back pain. Like, my legs or my back's really bothering me now. Like it feels a lot worse. How's your leg? Oh, I haven't had leg pain in 2 days. Green light, centralized, perfect, right? Like you have a great response there. Where if you weren't familiar with centralization or you didn't understand what Kane had just said, where you can have an increase in proximal symptoms as the distal symptoms are lessening or going away, then it can be misinterpreted. So why don't we?
There's one other thing that I wanted to bring up. Just when you mentioned that, sometimes when you do have symptoms in your patient's back, I usually try to get the patient to distinguish whether or not it's their normal pain or if it's just soreness. Remember, when you're doing a repeated motions exam, you're moving people in a manner that they haven't moved in probably in several decades.
And to the end range,
you're doing it a bunch of times. Yes,
repeatedly to end range. It's not something people really have to do, right?
Yeah. Are they going to get sore? Probably. There's a good chance of them being sore, but there's a big difference between being sore versus their usual pain or their sharp
Yeah.
pain, or maybe it's like that tightness or whatever it is. Make sure that you're differentiating between your symptoms to know what exactly you're working with. And that's going to take a little bit of trial and error and also experience to learn that as well too.
Yeah, I think a
All
good
right, Mark.
example is just as something maybe where someone came in with right-sided lower back pain and right leg pain. They're doing an extension-based exercise. They come in, their leg pain's gone, but like, like I have my back pain. It's just it's I don't feel just on the right anymore. It's like kind of just across, kind of right in the center there. It's like, okay, yeah, you have your answer there. So yeah, good point, Kane. All right, let's get into. We talked about how it's MDT. It's an evaluation method that can be used as treatment. It's based off classification and self-management. Let's talk about the three main categories that we can use this method to classify with. So we have derangement, we have dysfunction, we have postural, and then there's a fourth category. It's other, which is kind of anything else that doesn't fit the three that I mentioned: derangement, dysfunction, postural. But the large majority of patients are going to fit into derangement. So let's start there. So just to define derangement, these are patients who have directional preference. They have a lasting improvement in symptoms in response to repeated movements or sustained loading strategies. They said they have directional preference. It's the only category that has directional preference. They typically demonstrate centralization, and we usually see it associated with movement loss. We talked about in previous episodes with people who have directional preference, which essentially we're saying derangement, they can be variable in their presentation. The symptom location, the duration of the symptoms, the quality of symptoms, burning, tingling, numbing, stinging, all those kind of things, they're very variable. So it's our job to develop a pattern and see what's going to get these symptoms under control. So now that we've defined it, Kane, how do you, someone who comes with derangement, they have directional preference, what's the treatment look like for someone with a derangement?
Repeat extension in lying or standing.
That's the episode and it's done.
So yeah,
Not wrong,
wrong. It really is as simple as that. And just like what we talked about in the last episode of directional preference, when it's there, it is there. Please do not miss this because it is a home run that you just got to hit. Like when someone has a derangement or directional preference, I don't care what you call it, but if they have this, and you give them the appropriate exercise that matches what they need. That's the dosage, that is the force, and then the frequency. Their symptoms just drop off the face of the earth pretty much. They are going to usually have, I've seen anywhere from like the average, I would say, is like 50 to 75% like reduction of their symptoms. They think that it's absolute magic when it works. It's just when it's there, you gotta hit it.
And you're saying that 50 to 75% reduction can happen almost immediately. They can do a single, 1 or 2 rounds and it can happen that quick.
Yes. And that is pretty much how I determine my dosage, right? So if they took 3 rounds to reduce their symptoms, I'm probably going to give them 1 to 2 rounds for home. If it's something where it's like, I think that they fit into this classification, but they're not completely demonstrating all of the clear indicators. Like not everything is textbook. I'm sure everyone realizes this, but when they're kind of like tiptoeing into that territory, I just give them the 3 rounds that we did. And I'm like, okay, we're seeing a trend here that's getting better. Let's stick with this for right now and see what happens, right? Like I don't always need to progress the force, but just letting them ride it out. And then lo and behold, the next time that they come in, there have been countless times now where the patient's just like, yeah, it's just like almost all gone. And then at that point, you may need to progress your force just to see if you can get it to further reduce. But your job is already done. You've already figured everything out. You've already gotten the exercise. It is done, right? So at that point, you are pretty much just trying not to mess things up.
Yeah, exactly. You said you get a clear response. Hopefully, it's a better response or improved, then you just kind of go with it. So this classification derangement, you're treating these people with repeated movements, right, into the whatever their directional preference is.
Yeah, for sure.
Okay, so let's talk about we have 4 distinct stages of treating a derangement. So Kay and I talked about in a previous episode about people with directional preference, what's happening, why are their symptoms reducing when they do a certain movement. The McKenzie Institute has a stance on this. They're kind of moving away from the anatomical description, which I kind of go with too. So it's mainly based off the clinical presentation. But the original thought was with the disc model, you are moving the disc material off the nerve root. And this is where the first name of the first stage comes from, which is reducing the derangement, right? So stage 1, reducing the derangement, basically finding the direction, the appropriate dosage and frequency of this movement that is sufficient to reduce their symptoms and keep them away. Okay. Once you've found that movement, you move on to the second stage, which is maintaining the reduction. Okay. It's great that they can reduce their symptoms, but are they able to keep it going for a certain period of time? We're talking like days at this point, not just an hour or two. Once they're able to get rid of their symptoms, and there's not like a hard set amount of time it takes to get to this next stage, but the third stage is recovery of function. Essentially, to begin this stage, they can't have any distal symptoms. They need to be able to consistently get rid of their symptoms with the movement, and they can only have local symptoms that aren't worse afterwards, and their movement isn't worse afterwards after doing new movements. So when you're at this recovery stage, you can, let's say repeated extension of the lying was their reductive movement. You can start to add repeated flexion in lying. You can start to have them do maybe previously provocative exercise or movements they were doing before. Let's say deadlifts were causing their leg pain. Now they're able to do deadlifts and it doesn't hurt. At this stage, you're essentially working in movements or specific exercise that were previously symptomatic that are no longer symptomatic, right? So they've done the work, their symptoms are essentially gone. Now they're starting to do things that they couldn't do before because of pain, but there's still guidelines we want them to follow in that they can't have distal symptoms. Their symptoms can't be worse afterwards. They can't have movement loss afterwards. And if they do have symptoms while they're doing the movement for recovery of function, they can't last, and they can only be local to the spine. Okay. And our fourth stage would be for prevention. That's basically teaching people, hey, if you develop spine stiffness, if these symptoms come back, you should address it by doing the movement that we did before, and then progressing through the stages on your own. Now, Kane, I know, like we've talked about the stages and stuff before. Like, do you follow these to a T? Like, how does that integrate into your practice?
Yeah, definitely do not follow them to the T. It really does depend on the symptom presentation. If they are low irritability, I am reducing their symptoms and then calling it a day for that day, especially if it's on eval, right? When they come in the second time, they're like, yeah, things have been good and they've stayed good. We're moving right on to testing the stability. And that's what I call it, is testing like the stability of their function rather than recovering their function per se, because I'm just trying to see if there's something that we can do that elicits their symptoms. And then I want to see if we can still reduce their now newly provoked symptoms. That's what I'm looking for, right? If someone is like truly asymptomatic at a point, and then after I just start loading them more and more and more, sure, we can call it recovery of function, but I kind of intertwine the two of where when we hit like that maintenance phase of we've got your symptoms to go down and to stay down, we should really be testing to see like how much further can we push this. And if your symptoms come back, it tells us, hey, we're moving a little bit too fast, give it some more time and we'll be good. And then we can revisit this the next time that they're in. I think that is just a way to kind of move through the system a little bit faster, at least for myself.
Yeah. And I mean, I think reduction and maintenance should look identical for most patients. not the movement, but the concept. And the recovery of function is for, I mean, at least for me, it's different for everyone. Some people get the standardized, okay, let's say they, the reductive movement was an extension based movement, then we are slowly integrating, like, okay, now I just want you to bend over every couple hours, just bend over, try and touch your toes 5 or 6 times, right? Some people get the, textbook prescription, but then there's other people who maybe at their baseline, there's a functional movement that, if they liked riding their bike, and after they rode their bike for 10 minutes, they'd be stiff and they'd have leg pain, right? So some people, like you're saying, recovery function, you start to do other things just to test the stability. Yeah, like I said, listen, man, you're doing it. It's different for everyone, though, different for each patient.
Yeah, and I would definitely agree with that. At least in my practice, I've noticed that if I just flexed a patient and their symptoms came back or didn't come back or anything like that, it seemed like patients were kind of lost when it came to figuring out, like, the same way that we ask patients when we're trying to reduce their symptoms, like, is it any better, any worse, is it the same? And they're like, it's a little, I get the same kind of response when I just start flexing them. And at this point, I just load them instead. I just have them do their previously provocative motions. I start giving them more functional patterns, deadlifts, squats, etc., different carries, and see how they respond to it. And most of the times they do perfectly fine. And at that point, they're doing something that's more functional. They're not really thinking whether or not, like, hey, am I getting some change in my symptoms at all? Most of the times they're just, oh, I can do this. I couldn't do this before. This is awesome. Right. So I think just like empowering your patients with something that is more practical and realistic in their normal day-to-day life, I found that to be a lot more successful for me, and how I help to return a lot of my patients back to their previous level of function.
Yeah, for sure.
All right, Mark. So the next one, dysfunction.
Here we go.
Where are we going here?
So dysfunction, another clinical presentation. They do not have directional preference. They demonstrate pain that is produced but isn't worse after completing a certain movement. It doesn't get worse throughout the movement, and it's only produced at a limited end range of movement. They don't have movement loss or pain in any other direction. It's just when they move into the movement that has the quote unquote dysfunction. And the goal here is to remodel the tissue. Let's just say hypothetically, let's take someone who, let's just say they sit on the computer for a lot. They have, let's say, an exaggerated thoracic kyphosis, and every time they try and extend, it hurts. But when they go back to the resting position, it doesn't. They're limited in that extension. Each time they do it, their symptoms are produced. They aren't worse afterwards. That is a yellow light. In dysfunction, it should only be yellow light. In that, instead, their symptoms are produced. They're not worse afterwards. The treatment for this is repeatedly working into that direction to, let's say, quote unquote, remodel the tissue so that the tissue adapts, they restore that movement, and they don't have pain when they complete that movement. There's a large time component to this presentation that the tissue's just, it's not like a derangement where you could get a huge increase or decrease in symptoms just by performing a single, 5-10, a single set of a movement. This presentation, it's already pretty stable. It's just when they work into that restricted tissue, it hurts, it doesn't hurt after. So this takes time to remodel. They usually say, 6-8 weeks before you start seeing results. But yeah, that's dysfunction. It's pretty rare. You won't see it a lot. Like we said, a large majority of people fall into derangement. But what you need to know about dysfunction is that really only one movement's painful and limited. Yellow light only, produce no worse, and it takes time. So this person, maybe you're not scheduling frequently. Maybe you see them in a couple days as they've been doing the movement to make sure their presentation isn't changed, because it shouldn't change since it's a dysfunction. And then from there, I don't know, you see them every 2 or 3 weeks just to make sure things are still there, but you don't expect to see a quick progress with this presentation. Kane, I know you certainly treat derangements. with the MDT model. Is dysfunction, at least in the spine, something that you treat using an MDT approach?
I will say I have not really seen a true dysfunction. Um, and if I have, I may have misclassified it as other. Um, but for the most part, I'm usually at least testing it out to see like how
Mhm.
they continue to do with their motion. And if I progress them all the way through their the force progression and I'm not getting a significant change in their symptom presentation, then sure, I'll just give them the exercise that I think that they'll benefit from for their HEP. But I'll definitely continue to include other things, mostly like activity reconditioning. That's at least like my approach to it. Is like if they are not like a clear cut responder to it, I'll continue to give them the motion that I think is going to help. But I also just want them to continue moving. You know, like
Yeah.
if our
Yeah.
goal is to get the tissue to adapt and to just feel better in general, then why are we not continuing to move them as well
Yeah.
too
Yeah. Yeah.
in other manners,
Yeah.
right?
And you'll
Like you
get
can do
that.
it in a
Yeah, you'll get that generalized effect just from doing exercise, right? Which, like dysfunction, it's a pretty stable. It's a stable presentation. The only thing they're doing is that you want them to do is move into that, poke into that pain. That pain should be produced every time they do the movement. Shouldn't be worse afterwards. So you're not making them worse. I think, yeah, I agree with you. I think just doing other things that you think could have a, generally benefit them, other exercise, like why not? Because it's not like it's a derangement where we have a single movement that's helping. We know it's helping, and adding other stuff can kind of make things a little bit cloudy. Like I said, dysfunction's stable. We know what's going on. We know it's not going to get worse, and I don't see an issue with doing other things with it.
Yeah, that is actually so true, which is like when you have a derangement, you can have a variety of levels of symptom irritability. If someone is low for their symptom irritability, sure, getting them up and moving to retest stuff, totally fine. They're not going to have any issues. Someone's high up on how irritable their symptoms are, they may not even respond well to the reductive movement on eval. Like you may get away with like doing 1 or 2 sets of 5 and then they're like, okay, we're good, you do one more round and things take a turn for the worse, right? But for a dysfunction, just like what Mark said, it is very stable. You are not expecting to make significant changes
Mm-hmm.
because you've already assessed and classified them into this. You're already seeing that maybe it gets like it produces their symptoms, but it doesn't make it worse, or it comes back down to baseline pretty quickly. So yeah, I see absolutely no issue with being able to push these people a little bit more and see what they can do. Like you're trying to get their body to adapt to these stressors. Like you want them to be able to move and to stay active and to show them like, hey, like this isn't a bad thing. Like it's totally normal for your body to do this. It will probably get better with time.
Yeah,
Right.
absolutely. Yeah, and
So
the other thing
that
with dysfunction too is that hypothetically it's due to a tissue restriction. Well, dysfunctions are always chronic because that takes time. So chances are this person's had this for, at the very minimum, like a handful of months. Typically, at least in
few
my experience,
years.
it's years, right? So like the person, and
Yeah.
it's not getting worse, it's not getting better, it's the same. So doing other things, like it's might as well give it a shot. The person's been dealing with the symptoms for a long time. It's not like they're not, and they've been the same regardless of what they've done. So really, small chance this gets worse unless it's been misclassified. But a true dysfunction, yeah, you just you're working into that pain.
So I think it's funny because we hit dysfunction. We're going to very briefly go through postural,
Yeah,
but
yeah.
then we're going to touch on other, which I think is going to follow a very similar, but a similar approach to dysfunction, but definitely more nuanced once we get to that point. But let's chat about postural. What are you typically seeing for these patients, and how often are you actually coming across something like this?
Yeah, I can't see if I don't know if I've really. It would be a stretch for me to say I've seen like more than one of these in the 7 years I've been a PT, but essentially the goal is these people, it's only local symptoms. Excuse me. And another thing with dysfunction is only local spine symptoms as well, or local to the joint. Forgot to mention that you can't have peripheral symptoms besides in the case in dysfunction of an adherent nerve root, which would be, nerve tension, right? We can just say nerve tension for that. But again, going back to postural is only local symptoms, local to the spine or joint if we're talking extremities. Once they get out of that position, the pain's abolished, it goes away. They have no movement loss. They don't have any pain with movement. So the only thing that's bringing on their local symptoms is a position. And there's a time component with it. So it's like, oh, if I sit like this for 15 minutes, my neck starts hurting. Oh, but once I sit up straight, it goes away completely. That's postural. So you don't see this commonly because people usually figure it out on their own. But if they haven't figured it out, the goal is just to set them up so they're not in that position that bothers them, right? So lumbar roll, different chair or something like that. But yeah, I mean, like I said, I don't usually see it. I mean, like I said, the vast majority of people are derangement or in other. So postural dysfunction are pretty rare in my opinion, at least from what I've seen. At least dysfunction for the spine. When we get to extremities, dysfunction I think is almost just as common as derangement. But yeah, postural. I don't think you need to think about it too much. It's just kind of, people figure it out on their own. And for extremities, they certainly figure it out on their own. It's like, oh, if I rest my arm on my chair for 10 minutes, my elbow hurts, and then I move it, goes away, and I can put it right back there. It doesn't hurt. It's like, okay, people usually figure out posture on their own, but it exists. It's there.
It's so interesting that for the both of us, we tend to not put a lot of stock into the postural classification, just because, like Mark said, most of the times people are going to figure out that it is related to their prolonged positioning. They're going to figure out a pattern and then realize, oh, I should change this. And as soon as they change it, it goes away. But the reason why I bring that up is because MDT is known for being big on posture, right? So like, it's kind of funny that we take this approach instead, where we're not necessarily telling you that, oh, you need to be completely upright or anything like that, but maybe just changing your positions is all that you need, because your body doesn't necessarily want to be in a static position, even if it's like quote unquote good posture. I'm sure that a lot of people know this, but being able to change your positions is what your body wants. It wants that movement. It doesn't want to be stuck into one position. That's usually when you get problems, right?
Yeah, and postural is its own classification, but that doesn't mean that's the only classification that gets a discussion about posture, right? If we have someone who, every time that they sit down for more than a couple minutes and they start to have leg pain, and we've determined they're a derangement, they might get some advice on posture. Hey, like, you can sit like this, but if it's bothering your leg, you got to find something else. You got to sit up straight or do something that you're not getting leg symptoms. Stand up, do your exercise. So it's a component that posture education is a component that you can integrate into other classifications, but it can be its own classification on its own if it meets that criteria. No movement loss, no pain with movement, only local symptoms after being in a certain posture for a certain amount of time.
Yeah, and the one thing that I will say, for if someone does present with like either a derangement or if it's a postural issue, because they're usually stuck into those positions, I will cue them a little bit more on their posture, but it's just like, hey, change your position. Maybe set a timer every like 15 minutes, however often that you're noticing that your symptoms are coming up, and change positions or do some sort of exercise, right? Like sometimes I'll give someone a slouch over correct, or maybe I'll give them like no monies with a band or anything along the lines of that, just to make sure that you're getting things moving a little bit better. And in the clinic, you can work on a couple of your posterior chain exercises, like different rows or extensions and stuff like that, just to make sure that they're strong enough to support that posture in our continuing fight against gravity. That's something I almost always tell my patients, is like, your posture is sort of important, but it's not the end all be all that everyone makes it out to be. But the biggest thing is you're constantly fighting gravity every single second of the day for the rest of your life. You're going to lose at one point or another. The thing is, how long can you keep that fight up for, right? And that's where I usually try to emphasize, like, make sure that you're strong enough to and equipped to do the day-to-day tasks that you want your body to be able to do.
Yeah, I mean, I usually explain it to people just based on their symptomatic response. Like, hey, if you're sitting like this or standing like this and it's lighting up your leg or your arm, we got to switch it. But once these symptoms are gone for a little bit, you sit however you like for however long you like. I don't care. But for now, we know it's doing something to your symptoms. We have to address it. So let's look at, you have the three main categories: derangement, dysfunction, postural. We have a fourth category, which actually makes up, it doesn't make up as much of a majority as derangement, but it comes in second place, and it's not, I think the McKenzie Institute is doing more to address this category, which is the other category. I haven't taken a class, or I haven't taken an intro level class in like 4 or 5 years. So I don't know if they've integrated this at all, but I've heard they're looking to address this more specifically. And I think they're doing that because they're realizing there's a lot of people who are in the other category. So other is basically anyone who doesn't fit the other three categories: derangement, dysfunction, postural. So it could be, it could be something as severe as like a trauma or, an inflammatory type pain, or it could be something such as chronic pain, such as foraminal stenosis. And then we can get a little bit more like into MDT terms, where we have people who are mechanically inconclusive or mechanically unresponsive. So inconclusive in that they have, their symptoms may improve temporarily, but they're not better afterwards, or maybe sometimes they get worse afterward, or they get worse but don't stay worse afterwards. And unresponsive in that you move them and do stuff and it's just kind of all over the place. It's not really consistent anyway. So there's not really,
or it doesn't change.
Yeah, there's no response, right? It's just kind of like, okay, what do you do with this person? They say they have like 8 out of 10 pain, but they can move and they're fine. Nothing changes, right? So there's not, at least on my understanding from this point, there's not a specific interventions that MDT recommends to do for these presentations. It's kind of like you do, like you're doing whatever other kind of PT that right? Now you can certainly integrate the traffic light system and the movements, right? Like the repeat extension line or cervical retraction, like those aren't like, MDT movements. They're movements that the body does, right? So you can integrate those into the treatment for these conditions, but there's not like a specific recommended way to do it from the MDT standpoint.
So it's funny that at least when I was introduced to the system, other was kind of put on the back burner, and it didn't seem like it took as much of a priority.
Yeah, when I took A and B, it was just kind of like, yeah, it's there. But now, like the data that's being collected, like at least when I took A, like 6 or 7 years ago, it was like derangement was like 80% of the people, and then there was like 10% other, or 10% dysfunction. Like it was like really different than what it is now, where it's like, I don't know, 50% derangement, 30%, 35% other, and then, dysfunction postural, or the remaining 15%. And I think at least that is a way more in line with even back then when they were saying derangement such a high percentage. Like I feel like I see a lot of other. If they're not derangement, they're other. That's what it seems like to me.
Yes, that is like a very, very good approach. I think that honestly, dysfunction / postural can pretty much be placed way lower on your what you would expect to see, and other is like should be high up
except
there.
For I will say for extremity dysfunction is pretty prevalent, but for spine, I don't know how much you got to think about dysfunction or postural there.
Yeah, and for other, it's so interesting to see. These are the types of patients that, and we talked about this in previous episodes, right? Where if someone is a directional, has a directional preference, that's what what we're looking to give them, right? But if they don't match into that, if we go into our hierarchy of of impairments, then we realize, oh, now it becomes motor control, a loading strategy that they need to implement, or that we need to recondition them back into their activities, or just to get them to adapt, right? So for me is a handful of things. I need to figure out, are they having like non-mechanical low back pain? Okay, awesome. Those are the people that I'm doing more motor control stuff. Those are the people that I'm trying to recondition. And then usually you'll notice that their symptoms start to get better over time. But then there is a secondary bucket that I usually will see people in the other category. And that's usually when they have symptoms that are ridiculous in nature, but I can't do a single thing about it. I cannot change their symptoms. It's like it gets worse, it stays worse. Maybe I could continue to make it worse, but it certainly isn't getting better, right?
Yeah. And the term for that, this is just you saying that popped in my mind. They have established, they'll call it mechanically unresponsive radicular syndrome. And these terms are changing all over I think even the most recent class I took, they had something different for it. But just know, and what Kane's describing is that people are having symptoms and they're just not changing with movement. That's the presentation he's describing specifically.
Yeah, so for patients like these, this is usually where I just start to keep an eye on them, because I can't determine whether or not they're an other for the most part, like within the evaluation. I'm going to give it like a handful of visits before I'm like, okay, this is really not changing. We've exhausted everything, including the things that we haven't even talked about on this episode. But that really tells us that things are not changing. This is where we need to go somewhere else. And usually if I'm seeing someone who has ridiculous symptoms that are just not responding mechanically, it's probably time for pharmaceutical intervention. I'm probably going to punt them off to their pain and spine doc and see what exactly they're going to do with that, because there are only so many things that you can do. The fact that you've recognized that and classified that, I think, is fantastic. You're already putting your patients into a better position where they don't get lost in the healthcare system.
And that's the beauty of the system, man. I love how you're describing it, because you've taken a patient who maybe just by doing the chart, or you subjectively, it seems like it could be mechanical, but you've gone through your movement screen, you've assessed them mechanically, and you've determined that it's not mechanical. So MDT isn't just for people who have directional preference. It's for anyone with pain. And even if they don't fit one of the main three classifications, like Kane's saying, you've gone through the assessment, you've evaluated them appropriately, just based on their presentation, based on their, in this case, lack of response to movement, that that this kind of PT, physical therapy, may not be the answer for them, but you have a recommendation and a potential answer for them that isn't PT based off your MDT assessment.
Yeah, but also this is the other thing that's so cool about the other category is they come in for eval as an other. You send them and they get pharmacological interventions. They come back. They're no longer an other. They could be a derangement at that point. They could respond mechanically. That is one of the coolest things that you can see, is because now it's like, okay, we got you to the right person. We got you the right treatment. And now you come back and now you're mechanically responsive. Yeah. This I can work with. This I can fix. That is one of the coolest things, at least in my experience, where I'm like, okay, awesome, right? we got all the steps that we needed to get you to where you need to be right now. This is fantastic.
Yeah,
right?
There's a paper on that, exactly what Kane's describing, like people who were mechanically inconclusive or unresponsive to start with, they got a corticosteroid injection, I think, and the people who came back that their pain levels were significantly down. I think it was like a little over 60% of them were able to centralize or abolish their symptoms after getting it, right? So there's value in like integrating this assessment into I said, maybe people who previously are like, oh, I can't change it, you need to go get an injection. But now our plan is, hey, we have data to say in this presentation, If you get an injection and then come back and reassess, and then you match a category, you'll be better off than people who just got the injection and don't come back for a reassessment.
Yeah, because I mean, you could still have impairments, right? Like if you get your injection, you're like, oh, I feel fantastic. Like I'm back to normal, right? Like, hey, let me take a look. Let's see, just in case, because if it is truly just that you needed the injection, you needed steroids, whatever it is to get rid of that inflammation, that's awesome, right? But from what we've talked about previously, there is still a pretty big chance that something else is probably going on, right? Like if we can at least check that out and make sure that that is not going to come back and bite you in the butt later on in the future, like that would be fantastic. Like I want to make sure that you do not have to come back, that this does not continue to bother you down the road, right? And that's where, in my experience, I have seen plenty of patients that when they get their first injection, they're like, oh yeah, I feel better. You treat them, they respond maybe better, but it's still not exactly what you would want. And I've seen patients need to go in for a second injection. That is pretty common. And that I tell my patients straight up, like, hey, the first one may not bring the type of relief that you're expecting from this. It can, but it also might not. There's a chance that you might need to go in for a second, and it has happened. I've seen it, and then usually that second one does the trick. But that's something to kind of keep on your radar, just in case if the patient comes back in after the first injection or the steroid pack that they're given, and they're like, well, I don't really feel any different. Their symptoms aren't changing. Just stick with it. Make sure that you're giving it the time that it needs, but then also know that there's a good chance that they may need a second round of whatever the intervention is that the doc wants to give them, right? Mark, what's your typical experience with that?
Yeah, I mean, I can think of one person right away that had to go for a third one, but they came in between each injection, and their clinical presentation, in this case, it was essentially unchanged. So we were both on the same page about where they needed to be, right? We made a certain amount of progress. I wasn't changing past that. They needed a little bit extra. And even though I wasn't able to provide this person benefit in the clinic, they could see like, hey, I see what I need. I got 50% benefit from the first shot. Maybe I was able to move more and have less pain, but still, like, there wasn't any movement that was causing a lasting, they were completely unresponsive. It just, nothing was, they didn't have any lasting effect with any kind of movement. So they saw it, I saw it, like, hey, we know what you need to do. But they came in for, regular reassessments just to make sure we were still on the right track, or they were, the plan was still the appropriate plan. But yeah, that's what, like, even if PT isn't the answer for a certain patient, following this standardized assessment will give you that information. Okay, Kane, so that's the other category. Let's circle back, because I think when people think about McKenzie, when they think about MDT, even if they're not familiar with the term, they're thinking derangement, they're thinking directional preference, they're thinking repeated movements. So let's circle back to derangement, because we touched on the Traffic-like system. We said about a green light, you found the correct dosage, the correct movement to give lasting response. Let's talk a little bit more about a yellow light. Let's say you have someone come in and they have neck pain, they have arm pain, you have them do seated repeated retraction with extension. Their arm symptoms are centralizing during the movement, but they've returned. They're no better afterwards. They're back to baseline. What do you do? And and explain why you're doing it.
Yeah, so it's interesting because you would think that they already hit that green light. Things are so much better, right? But when they come back and they're like, it hasn't really changed, right? Or on the other hand, you may get the same type of patient where they're like, oh, I feel better. Okay, keep doing what you're doing. They come back for their second, their third, their fourth visit, and nothing has changed. That green light is now going back towards that yellow where they've plateaued. So if you're getting those types of symptoms where it's like, okay, better and then plateaued, or you're just getting a straight up yellow where nothing has changed at all, you got to progress forces, right?
Yeah.
So there's a couple of variables that you can mess around with. Like you can increase the frequency, you can increase the reps, or you can increase the force. And I think that if someone is stable, if someone has low symptom irritability, and you're getting positive indicators like it's a yellow trending on green, I think that progressing forces is very, very safe to do. It also tends to be the most efficient way of getting to the root cause. It is the variable that I am most likely to mess around with when I'm seeing those types of indicators, right? So if someone has those symptoms, and Mark used the example of retraction and into extension, right? I'm usually going to give them overpressure. So I'll have them add a wiggle at the end where they just they'll retract, they'll extend, and after that they start to rotate slowly and continue trying to further extend as far as they can go and see how that works out for them. Now, I think one of the things that I certainly can say that is probably does not align with the McKenzie vision is how I may deviate from their force progression. I realize that if I need to increase the forces, I can still certainly do so. It just may not match all the exercises that they may do. So for something like this, I can maybe give them a patient overpressure during their retraction and then have them start to extend. See how that works for them, right? The goal is still the same. I'm still trying to increase forces, but it's just done in a different manner. As long as it matches the goal of what you're trying to do, and that for me has helped me a ton when it comes to more complex patients where I'm just not seeing the changes that I want to see in their symptoms. What about for you, Mark? What are you typically doing to address something like this?
Yeah. So like in this situation where we're getting yellow light, there's some variability depending on the patient response, but usually something more has to be done. Um, especially if it's a decrease no better or centralizing no better type thing where they've had an improvement of symptoms during the movement, but it's not lasting. I'm progressing force. So this force progression is essentially doing the least amount of doing the movement that produces the least amount of force necessary to provide lasting relief. So if we let's just take the lumbar spine, for example. I think it's easier to explain. We all know pronon elbows are that sustained extension or in a prone position. If we wanted to progress forces from there, we could go to repeat extension, lying prone press up. If we wanted more, they could lock their elbows, exhale, sag the hips down. There's a progression from there where the clinician could add overpressure, and then we could mobilize their lumbar spine, right? So this progression gives us room to be able to progress forces when necessary to provide more lasting relief in symptoms. But like I said, we follow the traffic light system so that we know when to do that. If we're getting consistent yellows, force needs to be progressed. On the other hand, if we're getting a red light where we've started with a certain amount of force and their symptoms are peripheralizing or getting worse and they're remaining worse afterwards, we have to go the opposite direction. We need to regress forces or pick a force alternative, like maybe they were doing seated repeated retraction and they started peripheralizing. Then maybe we need to get them supine to offload the head, a force alternative just to take a little bit of little pressure off. So we're following that traffic light system. The force progression is built in there for patient safety, but it also lets us do the least amount of forceful movement possible to provide lasting symptoms. And it gives us it gives us guidelines and a framework to where to go. Do we need to progress forces with a certain movement or to regress? It's just based off the patient response. Okay, Kane, anything else you want to say about what we've spoken about today? Anything you want to add to the discussion?
Yeah, so just a couple of things. First, I feel like this topic is so in depth and nuanced that we could just continue talking about each of the individual things for
we could talk about each color of the traffic light system for like 3 hours. Yeah. So this certainly isn't comprehensive anyway. Like the courses for this, you have like even just the sorry, there's parts A, B, C, D, E. There's other courses from there. The first couple courses are like 4-day long courses, and they're just on like and we're trying to essentially summarize it for people in an hour long episode. It's not possible. So if anyone's interested in pursuing this more, we certainly encourage you to take the classes and get a more flushed out view of the system. But yeah, like Kane's was saying, it's kind of this is a very extremely broad overview.
Yeah, so I think that if people are interested, we can definitely talk about it more, and then just seeing like how we discuss and move through cases that are typically like not presenting the way that we would expect. I think that could be interesting. But the one thing I definitely wanted to touch on was like the last part where I said, oh, I'll add forces that are different than the system. What I will definitely say is please stick to the system when you're first learning. Like you have to know the rules before you can break them.
Yeah, it's
so
designed. Yeah, it's designed this way for a reason, right? Like we've talked about pattern recognition and learning from these patterns before. Like this framework it's standardized to the point where it gives you the foundation to be able to learn and identify. Right? You have classifications. You'll know when someone's in derangement. You'll know when someone's when someone's an other, when there's dysfunction. As long as you begin with the standardized assessment and then use the interventions in the almost algorithmic way that it's laid out, you'll begin to know when you can start to break the rules, give yourself a little bit of wiggle room.
Yeah, and I think honestly, the biggest takeaway that I would really recommend for the listeners on this episode is the traffic light system. Please utilize this, understand it. This is a pretty easy concept to understand at its given face value, but it is pretty in depth when you think about it and you apply it to more complex patients. Do not write this off as something that's like, like I know what this is. This makes total sense. Whatever, not a big deal. Definitely, take your time with the traffic light system. Try to utilize it. The second thing is understanding your categories. MDT is used as the framework to actually classify patients. So utilize the framework appropriately. That is what it's there for. It's fantastic for it.
Like we said, it's an evaluation technique or method. It can be used as a treatment. And this certainly doesn't mean that every single person gets repeated movements. That's not MDT. MDT is the evaluation. It's the assessment. It's the classification. Depending on the person's presentation and classification, it's treated differently. It's not just repeated movements.
Yeah. And then the last thing is, well, building off of that, I should say, is for derangement and for other, because they make up such a huge percentage of the patients that we see, make sure that you're understanding when something is a derangement or mechanically responsive. And then the other is make sure that if you're going to send someone that you know that they are truly mechanically inconclusive, non-responsive, or whatever the other reason may be that you're referring that patient. I think that's so important in helping to determine your plan of care, your prognosis, etc. And then lastly, understanding your staging for your derangement, the reduction, the maintenance, the recovery of function, and prevention. These are all the things that you need to make sure that, okay, we're moving from one phase into the next, and this is going smoothly. Here's what I should expect. If I add on to it too soon, here's how I know. And then it also doesn't hurt to add things on a little bit later if you're more conservative. That's fine too. But you just want to make sure that you've differentiated between those, so that way you kind of have a roadmap to help tell you where you need to be. And I think that those are probably the biggest things that I would at least take away and start to implement, whether or not you are a MDT follower, hater. I really do not care, but I think that those concepts are pretty universal. They aren't just something that's like only applicable to McKenzie.
Yeah, these concepts weren't just created for this method. If any across the board, I think they can apply in good PT practice. So there's a reason they're implemented in this system. Okay. And the one other thing I wanted to say, I mean, we gave a really brief overview here. The McKenzie Institute website has great intro resources for clinicians just to get an idea of what the method's like. You said, I think the classes are great. This method has completely transformed my practice, so I'll essentially always advocate for it. I think it's an exceptional starting point for new clinicians, and it's great for people who have been practicing for a little bit too. All right. Well, that concludes today's episode of the PT Good Podcast. Remember to leave us a like, subscribe to us on whatever platform you're listening to us on. Follow us on Twitter at PT Good Podcast. We thank you for listening. Hope you enjoyed. We'll see you on the next episode.
Misty, love you. Bye.